Hello, everyone. First of all, thanks for your kind invitation to your city. It's my first time in Belgrade. And I think my task is a little bit hard because it's the lunchtime. I will do my best, I promise. Whenever we were talking about the aneurysms in our friends, our colleagues, even surgical or endovascular surgical, it is hard to define an aneurysm and name it as a dissecting aneurysm in majority of the time. My topic is not the extracranial one, the intracranial one. When you look to definition of dissection, as everybody is aware, it is histopathologically well known that there should be a disruption of the intima and the blood flow in the media, and then the cascade of different histopathological actions maybe end with an aneurysm formation, maybe end with a stenosis. Everyone in the radiological field knows about that. But when you look the intracranial dissecting or dissecting like aneurysm, the morphology, histopathology is slightly different because that vessels contains different elastic lamina fibers and different histopathology. Maybe let us get different images because of those background. So the majority of the time, some atypical location warn us to name that the dissecting one, and morphology of the aneurysm slightly different than regular saccular one, and also additional CT and MR findings at that diagnosis a lot of value. Nowadays, last 10 years, and the endovascular imaging with the catheter, sometimes by using plain view, sometimes ultrasound, started to show us the dissection point, especially in the proximal vessel. But it is still on the way. There is still way to go because the catheter used for that images is rigid and cannot reach that distal territory. Whenever we saw a distal aneurysm, some sequence of MR cannot help us too much because of the differentiation of slow flow or real wall cannot visible most of the time. We need to evaluate the aneurysm second wall carefully by doing different sequences, of course. But I suggest all possible distal aneurysm or proximal, we need to use the contrast-enhanced MR angiography, not the regular TOF images. This is DSA, 3D DSA images. As you see that the dissecting type fusiform aneurysm contains both distal side branch in it. As I told you, the regular conventional images may not help you, sometimes give you false images, and the contrast enhanced is important. But the gold standard, of course, the groin puncture DSA. What we are seeing from DSA, again, these are very well described. Focal vessel irregularity, tapered vessel, and the parent string sign. But for me, the retention of contrast medium is important. Even I am looking at the saccular images, that the saccular images has the inflow zone and the turbulent flow and outflow zone. And the isolated local wall dissection can be occur in the saccular wall also. I mean, the aneurysm contains additional dissecting aneurysm, and then we call those groups the pseudo aneurysm. The surgeon is better aware of that when they tried to reach the aneurysm, they found only the thrombosis in that ruptured point. When you go that deeply, it is more confusing in terminology. But we rarely see intimal flap. We rarely see double lumen in intracranial vessels with aneurysm. This is the fetal type posterior communicating artery ending the posterior cerebral artery. Look at the contour is changing here. This is a dissecting type aneurysm. In this region, the main anterior thalamic artery is arising, and this is the ischemia secondary finding. And sometimes you can find that the perianeurysmal or intraaneurysmal thrombosis in non-contrast enhanced imaging, but should be carefully evaluated because of the slow flow. While I intended to treat this with the flow diverter, that waiting week, the patient cured itself. Actually, I wrote these group, the isolated posterior communicating artery dissecting aneurysm. You can find in neuroradiology last year. And after that one, I don't know, it is the humidity of Istanbul. I treat another 2 aneurysm, isolated posterior communicating artery dissecting one. It's totally 8 or 9 right now. It's the vast group of described in the literature. Look at this. Some location, we are just saying that, okay, enlargement of the vessel with a fusiform nature in 2007. Patient has a headache, that's it. Good. What's happening in 6 years? See, sorry. Is it working? Yeah, okay. Look at that. That segment becomes longer and longer, and then the old segment become a mass. Even because of the mass effect, that perimass edema appeared, and only 6 years, that segment is changed. And we call this one as the serpentine type aneurysm. Like river, that blood find its way to go through to the thrombose, and that way is changing every year. Like this, you see the thrombose portion and the visible portion of the vessel. Actually, even though that picture is very frightening, and because of the displacement of the surrounding vessels, the treatment is really very easy for us to just occluding the parent artery, a couple of coils. If the patient has a chance to have good pile collaterals, no infarction at all, and majority of the patient cured without infarction. Because it is a chronic stage, that chronic stage let the possible pile control collateral is moderating. And so that group, of course, get 2 options for treatment, surgery and endovascular. You will see endovascular one right now. Then one is the parent vessel occlusion. I prefer to occlude the dissected vessel if it's ruptured, par principle. Well, if it is not ruptured, we have ability to do more. The circular component occlusion with or without some stents, and hemodynamic treatment, especially that is important for dissecting one. We can change the flow antegrade or retrogradely. Of course, the surgery is possible in certain aneurysm, especially the proximal V4 segment aneurysm, and then the bypass surgery is sometimes necessary. But when the surgeon approach of aneurysm and see that the dissecting aneurysm, the only thing to prevent the parent vessel of those group is the wrapping. Other than the wrapping, it is not easy to clip those aneurysm because of the nature. Another posterior communicating artery aneurysm, as you see, and at the same infarction, anterior thalamus, close to the gena, the same location, never change. If you saw this, please look at the posterior communicating artery and occlusion of the parent vessel, because there is a P1 here. The same. Aneurysm, look at the sluggish flow in it. Look at cone shape starting and then sluggish flow. The same infarction. While I'm planning the treatment, the nature do its duty. It was occluded when I got it. And it is three months later, nothing. I treat this case in 2001. Again, the same infarction. The big one. Look at the proximal portion of the posterior communicating artery. And this time, at those time, we hadn't got the neuro stent. This is the coronary stent, AVS7. It is located in the posterior cerebral artery, and one coil to prevent flow coming from the anterior part of the posterior communicating artery. That's it, nothing in it. Just changing the flow around the aneurysm. This is one of the first cases on hemodynamic treatment of the aneurysm. And this is 5-year follow-up. The aneurysm shrink, the elevation of the P1 disappeared, and nothing at all. But sometimes you need to be hurry, because like this, that M1 segment contains an fusiform aneurysm. As you see, this is the rupture point. This is the subarachnoid hemorrhage. Nobody wants to touch it, and after a week, he came to us. Normally and theoretically, when you look at this aneurysm, almost every lenticule stride artery should be occluded because of the dissection. Because this dissection is not actually protecting the perforating arteries, and is having a road in the vessel wall and occluding all possible vessels. It is theoretically like that. Let's treat this case. And this is the hemodynamic treatment again, the combination of the long Leo and the one silk in it. As you see, immediately after directing the flow from healthy vessel to healthy M2 segments, look at the perforating arteries is visible right now. This is one day post-op images. Aneurysm almost gone. One of the big features of that dissecting aneurysm, whenever you redirect the flow, how fast that thrombosis is unbelievable. It is not like this in saccular tip, maybe because in the dissecting group, the wall factors, endothelium, subendothelial factors are different. This is second month follow-up. Aneurysm gone. The patient had lenticule stride infarction here, and this is the residual part, but the neurologically good. And this is the 3 years follow-up. No problem, nothing. And the patient has a normal vessel right now. We cut aspirin Plavix also. No drug at all. This is the vasosity of this case. Look carefully how the lenticule stride artery preserving in that dual layer stent area here. I think the dissecting make the segment is elongated. When it started to heal, again some kind of shortness of that segment appeared. This is my theory. Again, a ruptured case, he was a physician's son. The first day, we found that mid-basilar segment aneurysm. Again, it is not typical for saccular aneurysm group, even though this is a saccular shape looking. And because of the vasospasm period and necessity to do external drainage, first we use the balloon remodeling technique and coil it without stent, because as you know, when we put the stent, we are giving aspirin Plavix. Look at that. It is 9 days later. Something starting here. And when we passed the vasospasm period, we did an angio and see that that point is still growing. And another coiling technique, and then this time we have right to do the stent, easy to put the stent, and this is the fret flow diverter stent. It is nice picture. Everybody is happy about that. See? Perfect. But I never say perfect in any aneurysm, not only the dissecting. He came back this time with a mass effect of the brain stem. This is different. This is not rupture. This is not the vasospasm. This is something different. Look at that. Look at the age of the clot in the regrowth one. It is not normal. Look at that. Still going on. Look at the coils. And this time, we squeeze the thread with the pipeline, have a better compression of the thread into the vessel. And then he improved in 3 months without any neurological sequelae. That's why if you feel that it is a dissecting aneurysm, you should be careful in follow-up period. It should be not routine. Everyone here dealing with cranium, seeing those kind of patients. Think about that syndromic cases, Ehlers-Danlos, neurofibromatosis, fibromuscular dysplasia. Sometimes without syndromes, we are seeing that dysplastic vessels. Some of them calcified, some of them not. Some of them partially enlargement, some of them some stenotic lesions. How we are following them? Look at that case. Headache, simple headache. Who will treat this one in this period? Very rare. But in 1 month, look at that. It is better to treat those groups before rupture. It's obvious. And after getting more and more experience in dissecting like aneurysm, I'm getting more aggressive on those groups. Because we were getting those patients at the beginning, before 1994, 1995. For example, 1997 here, ruptured one. And while coming to us, it's only 1 month between two pictures. Look at that. All the segments look ugly. Anyhow, we have balloon remodeling technique at those times with a nice occlusion of the sac portion. What else? We didn't treat the patient because we don't know the transition zone. But I have still some hesitation. Should we name those group as a dissecting group? But nobody can answer this question all around the world to me with another name. That's why it is better to continue on not a perfectly dissecting terminology, but maybe the dissecting like fusiform is a good terminology to cover almost all possible pathologies. Maybe we will know in the future. Look at that, and ruptured, acute period, the first day, the baby. And how can you treat this? No collateral flow. You should preserve the internal carotid artery. This is the technique. You are, while deploying the stent, you are squeezing your coils against the wall and creating the peristent occlusion device like this, like a tent. And then having such results, especially the rupture point is occluded. And then in this group, early control angiogram is necessary. This is the 3 months, and look at that. It's good. No fusiform enlargement, nothing at all in that coil segment. Always, when you put some materials, always we are doing MR angiogram with contrast, like this. You can able to see the instant segment. Another one, rupture, same location. It is impossible to have a circular aneurysm at the upper wall of the C1, C2 segment of the internal carotid artery. There is nothing arising from there. Only the posterior communicating artery, anterocordial artery, before them, the superior cerebellar artery. That's it. There is no explanation that this is a circular group. You cannot explain that. It came to me 1 month later. You see that the blood is disappeared, and then I have easy to give him the aspirin Plavix and treat the flow diverter, especially in this proximal dissecting group. Flow diverter works fantastically nice And because of, I think, that invisible flap or dissecting part of the pathology compressed against the wall and letting the wall healed properly. Another location is the superior cerebral artery P1 bifurcation. And this is also a very prominent location for this group. And again, we did our best. The first treatment in 2009, telescopic 2 enterprise. The first flow diverters appears in that years. And then it didn't change. The second treatment 2 years later, this time we're better. We have a braiding stent, the Leo and Silk. Perfect, 4 stent. This is 4 years later. Nothing changed. No symptoms. We cannot send the patient to operation. We cannot put coil in it. We cannot pass through that 4 stent. We're in the jail right now. We just crisscross our fingers and wait. So I don't want to go in details that the medical treatment of the treatment, the strategies in the acute stage, but we have different strategy. If you ask me, I will describe to you. And how about surgery? Okay, why we are doing this one, the surgeons are good things. Yes, they are doing sometimes good things. The ruptured one, again, that parophthalmic segment aneurysm looks circular. In 1998. And they did a good job. They did a great job. This is the clip. Look at the vessels. Perfect. Nice. All the aneurysm done by me, by the way, that patient's. And she's asked me to do the angio after surgery. That's why I can collect all the data from that case. Let's look at the 50-year follow-up. What's happening? There is something happening there. Distally. Good, no symptoms at all. Let's go for the 9-year. That enlargement is bigger. Again, no symptoms at all. Just for, as you see, the 5-year, 9-year follow-ups. Let's look at the 14-year. With an headache this time. Unusual headache. Waking up her from the sleep. Now, that enlarged portion create a circular component. And this time, I did a flow diverter treatment. I didn't wait to rupture. Anyhow, she's good right now. Last group slides. Look at this one. One of the nice location of dissecting group is the vertebral artery, basilar artery junction, or the V4 segment. You see the feeling of that the aneurysm is a huge aneurysm like that, treated with the balloon occlusion, because the majority of the aneurysm arising from the left vertebral artery, without any problem. The patient came to me at those times with a mass effect. And when you look the new angio, because she came back with new symptoms, And I checked with DSA to see any possible feeling. No, nothing. Everything is perfect. Let's see the follow-up radiological images of those cases. This is in 1999. The CT shows the aneurysm, partially calcified wall. And they look at the aneurysm segment, the aneurysm sac itself. The different signal intensity changing by years. This is the last group. There is something very bright here, but there is something very inhomogeneous here. But no brainstem edema with diffusion, the images also. And when you look the T1 weighted images, this is immediately after occlusion of the artery. This thrombosis starting around of the sac. And now when you reach these in 2014, look at that, there is a contrast enhancement around the aneurysm. Another axial view, as you see, look at that inhomogeneous portion has some contrast enhancement, like metastasis, like the cystic glial tumor. But there is no feeling in the aneurysm sac. When you do it in the intra-arterial, the vaso CT, flat panel detector CT, you can easily appreciate that those tiny feeding vessels. this is it's a living structure. It looks like a tumor, and it is not filling portion. Maybe that vasovasorum is we don't know too much about the vasovasorum, and very interesting finding of those group. Whenever I saw a non-syndromic dissecting like aneurysm, I never is bad word, but I didn't see up to now another aneurysm in the same patient in another location. One attack. But we are seeing sacral aneurysm, and for example, we are treating MC aneurysm on the right side, 5 years later the patient creating another aneurysm on the other side. But in this group, I didn't treat up to now. I'm seeing a lot of dissecting aneurysm. I didn't treat any case secondary treatment. So we should work on it, and all the diagnostic team of us should work on it properly, and we should find some way than those available treatment techniques. Thanks for your attention.